Can stress make type 2 diabetes worse? You might be surprised to learn how deeply psychological stress can impact this condition. Beyond the daily management, stress plays a complex role, influencing both the development of diabetes and its long-term complications. Let's explore the latest research on this critical connection. Psychological stress is increasingly recognized as a significant risk factor for developing type 2 diabetes. But the journey doesn't end there. Living with diabetes itself is inherently stressful, demanding strict adherence to treatment regimens. Patients often grapple with the fear of hypoglycemia and constant worries about their future health. This unique burden is captured by the concept of diabetes distress. High levels of this distress have been consistently linked to poorer glycemic control, as measured by HbA1c. While some studies show mixed results, psychological interventions targeting diabetes distress have successfully improved HbA1c levels. So, how exactly does stress do this? Let's look at the science. The answer lies partly in endocrine dysregulation, specifically concerning cortisol secretion. Cortisol, often called the stress hormone, stimulates glucose production in the liver and promotes fat breakdown. This can lead to increased blood sugar and the accumulation of harmful visceral fat. To assess long-term cortisol production, researchers use hair cortisol concentration, or HCC. Unlike fluctuating blood cortisol, HCC provides an integrated measure over several months. Studies have already shown higher HCC in people with diabetes compared to those without. Diabetic complications are a major concern, increasing both morbidity and mortality. These include macrovascular damages like heart disease and stroke, and microvascular damages such as kidney disease, nerve damage, and retinopathy. Interestingly, chronic stress can promote inflammation and oxidative stress, which are also key drivers of vascular damage in diabetes. A recent study aimed to investigate the association of both chronic psychological stress and diabetes distress with metabolic outcomes and microvascular complications in type 2 diabetes. The research team recruited 127 participants, aged 40 to 80, from the University Hospital of Heidelberg and public advertisements. Exclusion criteria included heavy smoking, drug use, or excessive alcohol consumption. The study included a control group matched for age and gender, ensuring a robust comparison. After excluding a few participants, 73 individuals with physician-confirmed type 2 diabetes remained, 57 of whom had microvascular complications. This allowed for detailed comparisons within the diabetic group. Participants underwent examinations after an overnight fast. They completed various questionnaires assessing chronic subjective stress. Blood samples were taken to measure metabolic parameters like HbA1c, HOMA-IR, insulin resistance, and C-peptide. A hair sample was also collected from the scalp to determine long-term cortisol levels. Microvascular complications like retinopathy, nephropathy, and peripheral neuropathy were confirmed through medical records or additional medical examinations. This comprehensive approach ensured accurate assessment of both psychological and physiological factors. The study utilized well-validated questionnaires, including the Perceived Stress Scale, PSS, and the Screening Scale for Chronic Stress, SSCS-TIX-12. Crucially for diabetes patients, the Questionnaire on Stress in Patients with Diabetes, revised QSDR, was used. This specific tool assesses the daily burden of diabetes and its therapy across various domains. It helped evaluate differences in self-perceived illness-related stress between patients with and without complications. The study yielded several important insights. Hair cortisol concentration, HCC, was significantly higher in patients with type 2 diabetes compared to the non-diabetic control group. While not statistically significant, there was a trend for higher HCC in diabetic patients, with complications compared to those without. This suggests a potential link between long-term stress and complication severity. Regarding subjective stress, the results were more nuanced. A significant interaction between group and gender emerged for chronic stress scores. Women with diabetes reported higher chronic stress than female controls, while men showed the opposite pattern. However, general perceived stress, as measured by PSS and PHQ, did not significantly differ between diabetic patients with and without complications. The Diabetes-Specific Distress Questionnaire, QSDR, told a different story. Patients with complications reported significantly higher distress related to work and physical complaints compared to those without complications. This highlights the specific burdens faced by individuals managing advanced diabetes. Further analysis revealed important correlations. Higher HCC was associated with a longer duration of illness in type 2 diabetes patients. Interestingly, HCC was not significantly related to subjective measures of chronic stress, reinforcing the idea that biological and perceived stress are distinct. Crucially, diabetes-specific distress, QSDR scores, was positively associated with higher HbA1c, increased insulin resistance, HOMA index, and longer illness duration. The findings confirm that hair cortisol levels are elevated in type 2 diabetes patients, aligning with previous research. The positive association between HCC and illness duration suggests that chronic physiological stress may accumulate over time in diabetic individuals. While a direct link between HCC and complications wasn't definitively proven in this study, the trend is compelling. It's important to remember that cortisol is just one piece of the puzzle. The relationship between stress and diabetes is multifaceted, involving the immune system, inflammation, and insulin resistance. The lack of correlation between subjective stress and HCC underscores the complexity. What we perceive as stress might not always translate directly to physiological cortisol output. A key takeaway is the distinction between general perceived stress and diabetes-specific distress. While general stress wasn't strongly linked to metabolic outcomes or complications, diabetes-specific distress was. This suggests that once diabetes develops, the unique challenges of managing the condition become the primary source of stress impacting health outcomes. Psychological interventions, therefore, might be more effective when tailored to address these specific diabetes-related stresses. This study, while comprehensive, had limitations. The relatively small number of participants without microvascular complications limited the statistical power for certain comparisons. Future research could benefit from recruiting more individuals in this specific subgroup. Additionally, the study's cross-sectional nature means it can show associations, but not cause and effect relationships. Future studies should employ longitudinal designs to establish the chronological order of these associations. Exploring high-stress subgroups and utilizing advanced technologies like multimodal sensing could provide deeper insights into real-time stress responses and their impact on metabolic parameters. This could lead to more personalized and effective interventions. This research underscores the critical role of psychological stress in type 2 diabetes. While general stress may not directly impact illness severity, biological markers like hair cortisol are elevated, and diabetes-specific distress significantly correlates with poorer glycemic control and complications. This means addressing stress is not just about feeling better, but about managing the disease itself. For healthcare providers, this highlights the importance of screening for and addressing diabetes distress, not just general psychological issues. For individuals with diabetes, understanding this link empowers you to seek support for the unique challenges of living with the condition. Take action today. If you or someone you know is struggling with diabetes distress, talk to your healthcare provider. Explore resources like diabetes education programs, support groups, or mental health professionals specializing in chronic illness. Share this information with your community to raise awareness about the profound impact of stress on diabetes management. Let's work together to improve outcomes and quality of life for those living with type 2 diabetes.